Okay, so heart failure is a topic that's been discussed with you guys in your first semester and second semester of nursing school. So today I'm going to do some brief reminders of heart failure, kind of more chronic end stage, but the main focus that I am responsible for educating you on is acute decompensated heart failure. So in these slides, I'm not going to voice over, I don't start the voiceover again until slide 9. So slides 2 through 8 are more for your information to kind of help you remember what heart failure is, the etiology, the pathophysiology, what left-sided versus right-sided means. These should all be refreshers for you. And then as you progress through the slides, there's only, I don't know, 27 slides. And I would say there's only about 6 of those that really get into full detail of acute decompensated. The rest is more reviewing the already knowledge you should have on heart failure. And the difference between right-sided and left-sided as far as treatment and assessment. We're going to move into acute decompensated heart failure. Acute decompensated heart failure is defined as the sudden onset of signs and symptoms of heart failure requiring urgent medical care. So this is kind of when right-sided heart failure meets left-sided heart failure. So there's pulmonary and systemic congestion due to the increased left-sided and right-sided filling pressures. The universal finding for acute decompensated heart failure is pulmonary and systemic congestion, meaning severe edema and that pink frothy sputum that we talk about. So the patient's lungs have backed up to the point where they're not able to properly exchange gas like they should. In acute decompensated heart failure, the pulmonary venous pressure increases caused by failure to the left ventricle. This results in engorgement of the pulmonary vascular system. As a result, the lungs become less compliant and there is increased resistance in the small airways. To help compensate, the lymphatic system increases its flow to help maintain a constant volume of pulmonary extravascular fluid. This early stage is clinically associated with a mild increase in the respiratory rate and a decrease in the partial pressure of oxygen in the PaO2 off of an arterial blood gas. If pulmonary venous pressures continue to increase, the increase in intravascular pressure causes more fluid to move into the interstitial space than the lymphatics can move. So the interstitial edema occurs at this point. Then the patients become tachypnic, tachypnea develops, and the patient becomes symptomatic or they start feeling short of breath. If the pulmonary venous pressure increases further, the alveoli lining cells are disrupted, and if fluid containing red blood cells moves into the alveoli space, causing edema. As the disruption becomes worse from further increases in the pulmonary venous pressure, the alveoli and airways are flooded with fluid. This is accompanied with a worsening of the arterial blood gas, which means the lowering of the PaO2 and possible increase in the partial pressure of carbon dioxide, and they progressively move into respiratory acidemia. Acute decompensated heart failure can manifest as pulmonary edema. That's usually like the big sign. If the patient comes in through the emergency room with respiratory distress, difficulty breathing, and that pink frothy sputum, that's I can't even talk. That means that they are having an acute exacerbation or acute decompensated heart failure. This is an acute life-threatening situation in which the lung alveoli become filled with serosanguinous fluid, hence how the sputum becomes pink and frothy. The most common cause of pulmonary edema is left-sided heart failure, secondary to coronary artery disease. Is related to pulmonary edema, which is a common complication with acute decompensated heart failure. They're very distinct. So the patient has dyspnea, difficulty breathing, or orthopnea, which means they're not able to lay down flat. So that's usually recognized at nighttime. They sleep with several pillows or they sleep sitting up in a recliner. They have jugular vein distension. It's often present, and that's one of the most specific signs for elevated left ventricular pressures. The patient is usually anxious, they're pale, sometimes even cyanotic. Their skin is clammy and cold from vasoconstriction caused by stimulation of the systemic nervous system. Respiratory rate is often greater than 30 breaths per minute, and use of accessory muscles to breathe can be seen, or they may be seen. There may be wheezing and coughing with production of frothy, blood-tinged sputum. That's that pink frothy sputum we talk about. Breath sounds may reveal crackles and wheezes throughout the lungs. If there's an absence of crackles, that does not rule out acute decompensated heart failure, and many patients have history of chronic heart failure. They develop increased lymphatic drainage of the alveoli edema. The patient's heart rate is rapid, and an abnormal S3 or S4 can be heard due to the increased fluid volume. Their blood pressure may be elevated or decreased depending on the severity of the heart failure. Chronic heart failure is characterized as progressive worsening of the ventricular functions. Chronic neurohormonal activation that results in ventricular remodeling. This process involves the change in the size, shape, and mechanical performance of the ventricles. We want to try to avoid ventricular remodeling. We talked about that in relation to myocardial infarcts, that we begin ACE inhibitors soon within 24 hours after a myocardial infarct to prevent that remodeling. But this is something that just happens or it progresses over time with patients in heart failure. The clinical manifestations of chronic heart failure depend on the patient's age, any underlying type and extent of heart disease, and which ventricular is failing to pump effectively. The Heart Failure Society of America developed an acronym called FACES, which is here on your screen. So fatigue, limitation of activities, chest congestion, cough, edema, and shortness of breath. It's really important for you to remember this, the FACES, because that's your heart failure screening that you do. Those are the things you ask your patient. Are you having a hard time doing your daily activities? Do you find that you are requiring more rest? Are you having increased shortness of breath, any edema, but any limitation of activities? So say they live in a house that has stairs and they can no longer walk up the stairs without severe difficulty. Those are the things that you want to ask a patient when screening them about heart failure. Okay, some more clinical manifestations. We've talked about this. A lot of these have to do with regular heart failure. A lot of this is in review. So when it comes to fatigue, fatigue is one of the earliest symptoms of chronic heart failure. The patient notes fatigue after usual activities and eventually limits these activities. So they used to go on walks and they no longer walk their dog, or they used to go for a mile and now they only go for a block, or they no longer take the stairs, they take the elevators. The fatigue is caused by decreased cardiac output, which in turn has impaired perfusion to their vital organs, decreased oxygenation of tissues, and anemia. Anemia can result from poor nutrition or renal disease or even drug therapy, specifically with ACE inhibitors. Dyspnea is a common manifestation of chronic heart failure. It is caused by increased pulmonary pressures secondary to interstitial and alveoli edema. Dyspnea can occur with mild exertion or at rest, and then orthopnea that we talked about, it accompanies the dyspnea. So when you're questioning your patients, you want to ask how many pillows do they sleep with, or do you sleep in a chair? Those are important things to get from your patient to know if orthopnea is present. Paroxysmal nocturnal dyspnea occurs when the patient's asleep and the patient wakes awakes in a panic, feeling like they're suffocating, a strong desire to sit up or stand up. Um, and this is another thing you would have to ask your patient if they ever wake up, or they may have a cough associated with it. It's usually a beginning symptom, non-productive. Tachycardia is an early clinical sign of heart failure. One of the body's first responses to compensate for the failing heart is to increase the heart rate and activate the sympathetic nervous system. That helps to increase the cardiac output to help with the perfusion. Some more clinical manifestations of heart failure. We have edema. It's very common sign in heart failure. It can occur in dependent body areas like peripheral edema or the hepatomegaly. Very common um, that we educate our patients about edema, usually pitting edema, and how that relates to weight and their weight gain. Um, Over time with heart failure, the patient's heart can actually become enlarged or have a cardiomyopathy. Liver engorgement is related to restrictive cardiomyopathy. So that's one thing to consider too when it comes to peripheral edema, that it can back up into the liver as well. Um, the development of edema or sudden weight gain of 3 pounds in 2 days is often a sign of acute decompensated heart failure, which is an emergency. Um, so it's important to educate your patients that do have heart failure to keep track of that. Nocturia is the tendency to urinate excessively during the night. Chronic heart failure is frequently associated with poor renal perfusion and function. So patients develop increased peripheral and systemic edema at night when laying flat, which is why they avoid more in the evening. More clinical manifestations of heart failure. There can be skin changes because tissue capillary oxygen extraction is increased with a person in chronic heart failure. Their skin may appear dusky. Their lower extremities can be shiny or swollen with diminished or absent hair growth. Chronic swelling may result in pigment change of the skin as well, kind of like a brown or brawny, covering the ankles and the lower legs. Any Sometimes these patients have behavioral changes related to cerebral circulation that can be reduced, secondary to heart failure, and decreased cardiac output. Usually more common seen in late stages of heart failure. They can have coexisting psychological disorders, especially depression and anxiety, that contribute to risk of mortality and higher readmission rates. Approximately 1 in 5 patients with heart failure have clinical depression. Chest pain. Heart failure can precipitate chest pain or angina due to decreased coronary artery perfusion from the decreased cardiac output and the increased myocardial work. Chest pain may accompany either acute decompensated heart failure or even in chronic heart failure. Weight changes, as we discussed on the previous slide, many factors contribute to weight changes. First, there may be progressive weight gain from fluid retention, or renal failure may also contribute to fluid retention. Abdominal fullness from ascites and hepatomegaly frequently cause anorexia and nausea. So because of the increased size of the liver related to the increased fluid, whether it's from cardiomyopathy and liver engorgement, or it's ascites related to that heart failure, right-sided heart failure, they have a harder time eating as their stomachs are being pushed, or they may feel nauseous a lot of the time. As heart failure advances, the patient may have cardiac kind of like cachexia with muscle wasting and fat loss, and it can be masked with patients that are edematous, so they may have a lot of fluid in their extremities, although we call it their dry weight, which means without all the extra fluid, what their weight would be. Their dry weight actually would show malnutrition or a decrease in body mass index. Okay, so to continue on with heart failure complications, pleural effusions. Pleural effusion is a common complication with heart failure. There are 2 pleural layers or membranes: the visceral pleural lines, the lungs, whereas the parietal pleura lines the chest cavity. And I know that you've heard of visceral versus pleural or parietal pain. Normally, a small amount of fluid is between the two layers for lubrication to help aid in breathing, but pleural effusions occur when excessive fluid builds in the pleural cavity of the lungs, secondary to increasing pressure of the pleural capillaries. Fluid then moves from these capillaries into the pleural space. Pleural effusions may result in symptoms of dyspnea, cough, or chest pain. Pleural effusions we get into a lot more in our respiratory lecture coming up here in the next week or two. Dysrhythmias, excuse me, chronic heart failure causes enlargement of the chambers of the heart. This enlargement can cause changes in the normal electrical pathways. When numerous sites in the atria fire spontaneously and rapidly, atrial fibrillation, which we learned about, the organized atrial depolarization or contraction no longer occurs. So atrial fibrillation also promotes thrombus formation in the atria. As we talked about, it's not fully emptying, so blood pools and you're at higher risk for clots. Thrombi may break loose and form a clot. This places patients with atrial fibrillation at high risk for stroke. They require treatment with anticoagulations or cardioversions or ablations or antidysrhythmic drugs. Patients with heart failure also are at risk for ventricular dysrhythmias. Again, with that enlargement of the muscle, it's not as compliant. It can't do its function like it needs to. So ventricular tachycardia or ventricular fibrillation are common. Patients with decreased left ventricular function are at greatest risk for sudden cardiac death. So these patients often get an ICD or they're recommended to have an implantation of prophylactic implantable cardioverter defibrillator. So it's similar to like a pacemaker, but if your heart goes into one of those deadly rhythms, it actually, this defibrillator actually gives a shock to the heart to help. Then we have left ventricular thrombus. With acute decompensated heart failure or even chronic heart failure, the enlarged left ventricle and decreased cardiac output combine to increase the risk of thrombus formation in the left ventricle. Once the thrombus has formed, it may also decrease left ventricular contractility, which in turn will decrease cardiac output and it will worsen the patient's perfusion. The development of emboli from the thrombus also places the patient at high risk for a stroke. Again, with hepatomegaly, we've talked about this on previous slides. Heart failure can lead to severe hepatomegaly, especially with right ventricular failure, so right-sided heart failure. The liver becomes congested, as we know that right-sided heart failure results in venous backup of blood, and it can actually impair the function of the liver and cause more problems. So liver engorgement or enlargement is directly related to restriction of the ventricles due to misfunction or to cardiomyopathy. Okay, so now that we've talked about heart failure, we've talked about worsening heart failure, we've talked about end-stage heart failure, acute decompensated heart failure. Now we're going to talk about those patients with acute decompensated heart failure that are being hospitalized in an acute care setting, and what it means to us as nurses or what we're going to do about it. So these patients with acute decompensated heart failure, this means the right side and the left side aren't working. So if they were a previous left sider, now there's right side involvement, or if they're previous right, now there's left side. So this is both sided heart failure that's happened. This monitoring and assessment needs to be done continuously. So it's done in an ICU if the patient is unstable. In the ICU, we monitor the patient's heart rhythm, their oxygen saturations continuously. We assess their vital signs and their urine output at least every hour. Any patient that's in an ICU setting, we're monitoring those every hour. The patient may have some hemodynamic monitoring. That might be an arterial blood pressure. That gives us our cardiac output. Very rarely do these patients get a Swan-Ganz catheter unless they are getting to the point of transitioning into transplant. So once we've gone past acute decompensated, or we're in that acute decompensated, and their heart failures progress to a certain point, only medications and treatment can go so far before we need to consider a transplant or the option for transplant. These patients we provide supplemental oxygen to. We are trying to get their SATs to a stable level, usually in the low 90s. In severe pulmonary edema, the patient may need um, to be put on BiPAP, or in some cases they may need mechanical ventilation. We may actually need to have them intubated to give their heart some rest while we aggressively try to diurese them and get them on medications that will help improve the function of their cardiac output. So some patients with acute decompensated heart failure require hospitalizations but are more stable. So they can be admitted to a telemetry or a step-down unit for assessment and treatment. And these assessments are every 4 hours. We also are both times ICU and on the tele floor. We record the intake and output very carefully, and we do daily weights because that is the best way to evaluate patients' fluid status. If the patient has dyspnea, we want to make sure that we place them in a high Fowler's position with the feet horizontal in the bed or dangling at the bedside, because this position helps to decrease the venous return and the pooling of blood in the extremities. On acute decompensated heart failure, some options for treatment. Ultrafiltration is an option for patients with volume overload. It's the process of removing excess salt and water from the patient's blood. This can be done rapidly to help the cellular shift for the intravascular fluid volume while maintaining hemodynamic stability. So it's similar to kind of like a dialysis. The ideal patients for this treatment are those with majority of pulmonary or systemic volume overload who've shown resistance to diuretics. So we were unsuccessful in our attempts to diurese them. Also, it's good for patients that have coexisting renal failure. Also, in the ICU, circulatory assistance devices can be used to manage patients with worsening heart failure. So we talked a little bit last week about intra-aortic balloon pump. This is temporary. I want to emphasize that this is something that we can do to give the heart rest or to improve its function temporarily. This device increases coronary blood flow to the heart muscles and decreases the heart's workload through process. And we talked about that counter pulsation. So if you need to refer back to your balloon pump slides, the intra-aortic balloon pump is useful in hemodynamic unstable patients because it decreases pulmonary artery pressures and the systemic vascular resistance, which in turn leads to improved cardiac output. So that's something temporary that we would do for a patient in a true acute episode while we are trying to do other things to help improve the function and work of the heart. Ventricular assistant device, or VADs, can be used to maintain the pumping action of the heart that cannot effectively pump. A VAD is a mechanical pump that is surgically implanted. Once the patient is more stable, determination of the cause of the acute decompensated heart failure is important, but diagnosis of systolic or diastolic heart failure then direct further treatment and protocol. So the next slide is an animation picture of what an LVAD looks like. So let's talk some drug therapies for these patients. Diuretics are the treatment of choice for patients with volume overload. They act to decrease sodium reabsorption at various sites within the nephrons, and then in turn enhances sodium and water loss. So the purpose is to decrease the intravascular volume with the use of diuretics to reduce venous return or the preload. Subsequently, the volume returning to the left ventricle. This allows the left ventricle to pump more efficiently, cardiac output is increased, and pulmonary vascular resistance is decreased. A gas exchange is improved with loop diuretics. So this can be given IV I have had patients in an ICU setting that have been on Lasix drips, also Bumex drips. So these patients you have to very cautiously watch. They usually have a Foley catheter in place because we titrate the medications that are on continuous infusion based on urinary output. We're also very aggressively checking electrolyte status as we are diuresing anytime a patient has increased volume coming out excreted through the kidneys. We're at risk of depleting our electrolytes. So it's very important to keep track of that and to plan on supplementing. Vasodilators, the ones that we're going to talk about, IV nitroglycerin is a vasodilator that reduces circulating blood volume. It also improves coronary artery blood flow because it dilates those coronary arteries. Therefore, nitroglycerin reduces preload, slightly reduces the afterload when it's given in high doses, but it increases myocardial oxygen supply. When titrating IV nitroglycerin, anytime, and I've said this in class, anytime we're titrating IV medications that are on continuous infusion that control anything to do with the heart, we're monitoring the patient's vital signs, meaning blood pressure and heart rate, every 5 to 10 minutes to avoid any hypotension. Nitroglycerin also requires special non-porous tubing. Remember I said we talked about how nitroglycerin comes in a glass bottle. It's a non-porous container and it's sensitive to exposure. So that's why it's a non-porous tubing as well, or nitro tubing. Nipride is a potent IV vasodilator, and I don't believe that one's on your med list. So this is just a nice to know information. It's a vasodilator that reduces preload and afterload, and then in turn improves the myocardial contraction, increasing cardiac output. It also helps reduce pulmonary congestion. The complications with giving this medication can be hypotension, again, as a vasodilator. Hypotension and bradycardia are very concerning, so you want to be careful of that. If you use this more than 48 hours, the patient can become toxic. So this is a short-term medication used in an ICU setting, so you have to be careful because of the adverse effects. And then I don't even think this last one, Nitrecor, I'm not familiar with that, honestly. I don't believe I've ever given it, so we're not going to go over that too much, and I don't believe it's on your drug list either. Okay, so more on drug therapy. Morphine, we've talked about morphine a lot related to cardiac. It's a favored drug. Morphine sulfate reduces the preload and afterload. It's frequently used in treatment of heart failure and acute coronary syndrome, which we talked about. It dilates both pulmonary and systemic blood vessels. When morphine's used, the patient often experiences relief from dyspnea, and consequently their anxiety level also goes down, and the anxiety related to the dyspnea. You want to make sure to use morphine cautiously in patients with acute decompensated heart failure, though. Morphine is related to more adverse events, including a greater need for mechanical ventilation and more ICU admissions. Also, it is related to prolonged hospitalizations and higher mortality rates in these patients. So a little goes a long way. So you just have to be cautious of how you give it and do a thorough assessment of your patient. Positive inotropes. A lot of these medications listed here are on your med list, so I want to go into those in a little bit more detail. Inotropic therapy increases the myocardial contractility. Drugs include dopamine or dobutamine, norepinephrine, also the phosphodiesterase inhibitor of milrinone or Primacor, and digitalis. The B agonists are used as a short-term treatment for acute decompensated heart failure. Milrinone is a phosphodiesterase inhibitor that has been called an inodilator. It increases cardiac contractility and an inotropic effect and promotes peripheral vasodilation. Inhibition of this cycle or Does it have it on there? It doesn't, so I'm not going to go over that. It is given IV. It increases cardiac output. It's given IV on a continuous basis. It's usually dosed like micrograms per kilogram per minute. It also reduces the blood pressure or decreases the afterload. And like dopamine and dobutamine, this drug is available for IV use. Adverse effects include dysrhythmias, thrombocytopenia, or hepatotoxicity. Digitalis is a positive inotrope that improves left ventricular function. Digitalis increases contractility, but also increases myocardial oxygen consumption. Because digitalis requires loading dose and time to work, it's not recommended for initial treatment of acute decompensated. A lot of times, these patients that are diagnosed with chronic heart failure are put on it orally at home. Digitalis is the same as digoxin, which I know you guys are very familiar with. And so it can be given IV, but it's usually a maintenance dose given at home. So currently, inotropic therapy is only recommended for use in short-term management of patients with acute decompensated heart failure who have not responded to the conventional drugs that we've talked about. I really feel like this slide is appropriate for nurses because this is our main treatment goals. So everything that we do with these patients with chronic heart failure and acute decompensated all focus on these items. So treat the underlying cause and contributing factors. With addition to the new drugs and devices and the management of heart failure has dramatically changed in the past few years because of the larger focus on decreasing readmissions by Medicare, Medicaid, and the Joint Commission. A lot of these things, a lot of education has been done and a lot of progress has been made. Because of the large number of patients and high cost of care related to hospital readmissions, strategies to improve outcomes have been developed. One example is the use of guideline-directed medical therapy as defined by the American Heart Association. Another example is specialized heart failure inpatient units. So the nurses on that unit are specialized and trained and really do a lot of education and help those patients be familiar. Multidisciplinary teams are put into place to help these patients. The main goals of the treatment of chronic heart failure are to treat the underlying cause, which we talked about, maximizing the cardiac output, and reducing symptoms. All of those will improve ventricular function and the quality of life of the patient. Our goal is to improve mortality and morbidity and preserve the target organs. Okay, so now we're kind of moving backwards in the slides. So the main difference, we have right-sided, left-sided, systolic, diastolic, whatever kind of heart failure. And we've talked about that. I put voiceovers on there. I've reiterated a lot of it on these slides. We've talked about drug therapy and acute decompensated. This slide here talks about chronic heart failure. So when your patient's at home, beta blockers, oftentimes also ACE inhibitors, vasodilators or nitrates, whether that's nitroglycerin. I know I've talked to you about my patients in pulmonary hypertension unit. They were right-sided heart failure and they were all on nitrates, right? They were on sildenafil, aka Viagra. Combination therapies are very important. So let me see. Patients with heart failure who are getting optimal therapy with ACE inhibitors and beta blockers. The combination therapies is kind of important for these patients. Whether it's hydralazine combination of hydralazine and isosorbide dinitrate or Badil. Or ACE inhibitors and beta blockers. Those are good combination therapy medications. Positive inotropes, that would be your digoxin. That's going to help with your contractility. So your beta blockers and your ACE inhibitors help for preload, afterload, regulatory of the heart rate. Your vasodilators help for perfusion, whether it's right-sided, most of the time right-sided heart failure, or if it's as needed, like a nitroglycerin for left-sided heart failure. And then that positive inotrope, which helps with that cardiac contractility. Very important long-term medications that these patients should be on. This is just for chronic heart failure. The medications change a little bit in acute decompensated. Okay, so part of our job as nurses to make sure that our patients are properly educated. We're trying to avoid them from developing acute decompensated heart failure. So the most important thing that we can do is educate them and make sure they understand the education. Poor adherence to a low sodium diet and failure to take prescribed drugs as directed are two of the most common reasons for readmissions of patients to the hospital. Therefore, it's very critical that we accurately assess the patient's diet and teach both the patient and caregiver about importance of diet. One of the eye-opening things to me when I was talking to a patient before, they didn't realize that sodium was salt. So when the doctor said, a 2 gram sodium or 2 gram or restrict your salt, I think is what the doctor said. They didn't realize when they were looking at ingredients, it didn't say salt on there, so they thought they were okay. Also, understanding their habits. Are they fast food? Do they do TV dinners? Do they do canned foods? We want to try to avoid some of those things and eat more fresh fruits and vegetables, avoid those salty meats, ham, things like that. Part of our job is to obtain a detailed history so that we can help those patients with the education that they need. Um, the edema associated with chronic heart failure is often treated by dietary restrictions alone or the DASH diet. The DASH starts for the dietary approaches to stop hypertension. It's a very effective way, first line therapy to help individuals with hypertension. Um, it's also widely spread and widely used for heart failure with or without hypertension. The average American adult daily intake of sodium ranges from 7 to 15 grams. But commonly patients with heart failure, they are restricted to a 2 gram sodium diet. So it's really important that they find ways to restrict their sodium and to be aware of it. Fluid restrictions are not commonly ordered for the patient with mild to moderate heart failure, but patients in moderate to severe heart failure and renal insufficiency fluids are limited to less than 2 liters a day. Some doctors will say 2.5 or even 3 liters a day. So helping patients deal with thirst and side effect of the drugs is important. Ice chips, gum, hard candy, ice pops. I know patients that just get that kind of the crushed ice and they can kind of chew on that all day long and they'll never meet their 2 liter limit, but it helps keep their mouth moist and helps them feel like they are consuming fluids. We want to make sure to tell our patients to weigh themselves daily. This is important for monitoring fluid status. I feel like I've said this a dozen times, so we'll get that one right on the test, right, guys? Tell patients to weigh themselves at the same time each day. Keep a log. This should be done before breakfast. They should use the same scale, wearing the same type of clothing. This helps them to ensure comparisons from day to day. It helps them identify early any signs of fluid retention. So not only are we telling them to weigh themselves, but we're telling them to report weight gain. For patients with visual limitations, you don't need to do that. You can do audible scales. Tell patients to call their healthcare provider if they see a weight gain of 3 pounds over 2 days or 3 to 5 pounds in a week. Remember, 1 pound or 1 liter of fluid is equivalent to 1 kilo or 2.2 pounds. So if it's over um, over a week's time and they're up to 5 pounds, that's over 2 liters of fluid that they've retained. So it's really important to educate them and tell them the importance of keeping track of it. They can hopefully head it off, get it under control by contacting their healthcare provider. They may not have to go back into the hospital. They may do one-time diuresis of more Lasix that they normally take or something to that effect. But we're trying to avoid the acute decompensated picture that patients come in emergently with.